Good afternoon. Somewhere around 1996, I got a call from Governor Arne Carlson's office asking me to be on the Minnesota State Board of Medical Practice. The Minnesota Board of Medical Practice is the board that licenses, de-licenses, keeps track of our continuing education, and various other things that supervise the practice of medicine in the state of Minnesota. Most of you probably don't even know that it exists, and that's good. Most physicians don't even know that it exists until they get their annual licensure renewal fee, and that's also good, because nothing is more alarming than to get a letter when you're in the middle of your practice some morning saying, and look at the return and it says from the Minnesota Board of Medical Practice. Anyway, all professions, chiropractors, dentists, hairdressers, insurance agents have a supervising board, and most are licensed by the state of Minnesota. And so I thought it would be good. I put this program together myself. Since I am program chairman, I have a lot of discretion and just do my own thing occasionally. So when Ms. Martinez talks, just remember that almost every profession has a similar board that handles complaints, that keeps track of your continuing education, and occasionally has to remove someone from their practice. So I've known Ruth for probably 25 years since I joined the board, and we have remained friends, and she still talks to me, and she has never sent me one of those official letters. So, yet. So Ruth Martinez, thank you.
Thank you, Dr. Peter Smith, who is truly a dear friend and an 8-year professional peer, but a longtime friend. I'm grateful to be here. Very grateful for some of the conversation that began even before I got up to the podium today. Some of you approached me and expressed some of your own personal interests in this presentation today, and I'm delighted to talk a little bit more about who we are as a Board of Medical Practice, who we are as state regulators, and what participants you might be in that process as well. So I'll try and cover a whole range of things and hopefully some particular points of interest to you. First of all, let me just tell you a little bit about boards in general. In my own background, I've been with the Board of Medical Practice since 1988. Prior to that, I was with the Department of Commerce, also a regulatory licensing agency at that time that regulated insurance agents, real estate agents, and cosmetologists, if you can imagine that. There's now an independent board of cosmetology, by the way. But I came to the board a long time ago. We primarily licensed and registered physicians, and since that time we have acquired 7 additional healthcare professions. So the board is now responsible for the licensure and enforcement of 8 professions. So physicians, physician assistants, respiratory therapists, genetic counselors, acupuncturists, traditional midwives, naturopathic doctors, and athletic trainers are all under the jurisdiction of the Board of Medical Practice. There are now 16 health licensing boards. We are all housed together near the University of Minnesota campus, and we as boards have a very, even though we're independent state agencies, each of us with separate jurisdictions, we have a very collaborative relationship with one another. We have an executive directors forum that meets on a monthly basis to talk about issues of common interest, challenges that we might be experiencing, collaborative legislative processes that we might be engaged in. We are all subject to a joint section of statute under Chapter 214 that drives our complaint and investigative processes, some of our data sharing requirements, and so forth. So we have a lot of things in common, even as we are independent in our practice acts and regulatory roles and responsibilities. But we, among those 16 boards, we actually regulate over 230,000 healthcare providers in the state of Minnesota. So it's a significant number of individuals under our regulatory authority. I think a lot of people don't quite appreciate it, but to the point that was made about so many license holders in the state, we have quite a few of them under our jurisdiction. As a board, we ourselves have over 30,000 licensees at the Board of Medical Practice, and actually just over 31,000, almost 32,000 this year, and that's pretty significant number across the 8 professions that we regulate. Our newest profession is genetic counselors. They just came under our jurisdiction last legislative session, and they were all just required to be licensed by January 1st of this year. So that's been an exciting transition for that profession, and we are seeing a lot of interest and enthusiasm around the practice of genetic counseling in the state of Minnesota and actually across the country. So there are about 128 genetic counselors licensed in the state of Minnesota as of January 1st. The boards have a statutory mandate to protect the public. That is our primary responsibility. And we all function under a board model. Board members are appointed by the governor. The Board of Medical Practice has 16 members, 11 physicians, and 5 public members. They typically serve 4-year terms and may serve 2 consecutive terms. So as Dr. Smith did, he served 8 consecutive years on the board. In that process, they do a lot of their work in committees. So at the Board of Medical Practice, we have 2 complaint review committees. Each meets monthly to review complaints and investigative processes, propose disciplinary and corrective actions, address petition processes for returning licenses to individuals under order. Those are almost full-day meetings every month for the 3 members. We have 2 physicians and a public member on each of those complaint review committees. We also have a licensure committee that meets every other month, reviews applications for license, complex issues that might come up, disclosures on license applications. In the moment, they're doing a lot of work with the board's policy committee on making some tweaks to our Practice Act and doing some evolutionary changes to our licensing requirements. So we have a policy and planning committee that also meets at the moment, actually, because we're so close to session, is meeting every month. And we as a board are doing some modifications within our Practice Acts, the 8 Practice Acts that we have under our wing, to incorporate such things as birth month renewal cycles, and do a couple of tweaks here and there to some of our statutory requirements. So there's always a lot of work going on at the boards, and we are guided in our work by 7 advisory councils. So all of the allied professions, the non-physician professions, each has an advisory council that provides expertise on those 7 separate healthcare professions when needed, when we're processing complaints and engaged in investigative processes. We are legally represented by the Office of the Attorney General, the Health Occupations Division, and the Attorney General's office participates in all of our complaint and investigative proceedings. They handle litigation for us, conduct hearing processes, give us a lot of legal guidance throughout all of the work that we do. And the bulk of the work at the board is around complaint and investigative processing. We issue a lot of licenses, but we process somewhere in the neighborhood of 800 complaints annually. And so that's a very significant part of the board's work. And I invite you to stop me anytime with questions. So I don't want to make it a lecture. I hope I can make it more interactive. I know that I was asked coming in about what the board is engaged in on the opioid issue, and I want to really delve into that a little bit. I know the opioid crisis is very much on our radar, in our hearts, as we see so many people affected by addiction and the consequences of addiction. And the practicing community has responsibility in that. As we have traveled back in time, taken a look back, we recognize that the practicing community contributed to the epidemic that we're now experiencing, and we've seen a real sea change in how providers are educated, trained, what their actual practices are. So the board, this is just a misconception, I think, that the board actually establishes the scope of practice. The board is the enforcement arm, but we enforce whatever the practicing community establishes as the standard of care. So it's really the common practice among the community practitioners that tells us what the standard is that we enforce at any moment in time. But we've certainly seen that standard change, and certainly around the opioid issue. So I want to talk a little bit about some of the things that the board has been engaged in. We are very involved with internal and external stakeholder groups. So internally, all of the boards that have prescribers meet on a regular basis to talk about what we can do collectively and individually as agencies to address prescribing practices among our licensed professionals. We are part of the prescription monitoring program here in Minnesota, which, by the way, I think every state in the union except Missouri, and I think Missouri is almost on board with a prescription monitoring program. We now have that opportunity to actually check and know what controlled substances are being prescribed by an individual and what patients are receiving. And even though it's available and it's a wonderful tool, many physicians will tell you it's a little bit onerous to use it. And I'm really excited to tell you that there's a lot going on with technology in the moment. There will be a lot of enhancements, I believe, over a very short period of time as we have just embraced the prescription monitoring program here and across the country to start incorporating that PMP as we know it into the electronic health record and really making it much more functional for prescribers to use that significant, important tool. We're also part of external groups, a state opioid oversight project work group that feeds information through a National Governors Association group. We just came out with a report through the governor's office, and we are also contributing to information on the, there's a Dose of Reality website that is overseen by our Attorney General. We are also contributing and engaged with an opioid dashboard at the Minnesota Department of Health. And I will try and forward some links to all of this information. I opted to go without a PowerPoint today, but there's a lot of material out there, and I'd like to point you to some of the information that might be of particular interest to you. So I like to think that the pendulum is swinging to a better place in prescribing practices in particular, and I know that's a topic of importance to all of us. We're also doing some things to support accessibility to naloxone to counteract an opioid overdose, and I see we have law enforcement represented. I'm sure you're very familiar with the availability or the inavailability of naloxone at different points in time, and we are proud to be supporting that. In Minnesota, the boards of medical practice, nursing, and pharmacy as tri-regulators that interface frequently with prescribing practices. We've written several joint statements together on certain types of practices to give guidance to our providers, and one of the things we're tackling right now is naloxone prescribing for our licensees. So that's another topic of interest to us. We are part of the executive branch of government, as you know, and we have lots of different opportunities. So I want to make a pitch here for those of you who might consider serving on a board. We have many, many boards in Minnesota, well beyond the health licensing boards, but all of those applications go through the Secretary of State's website where vacancies are posted. Every board has public representation on it, and so if you are either a healthcare professional or a member of the public who might have an interest in service, I strongly encourage you and invite you to get on the Secretary of State's website and take a look at some of those vacancies and the opportunities that might be out there for you. I have been incredibly proud to facilitate the work of the Board of Medical Practice. In my almost 30 years with the board, I have seen board members come and go, and I can tell you that these are some of the most committed, thoughtful individuals that I have ever had the privilege of knowing, and it's truly an honor to work with someone like Dr. Smith and all of his peers on the Board of Medical Practice who make a commitment for a very small per diem payment. We don't pay our board members well, but we appreciate them greatly, and I know Doctor here in the room who has served as a consultant to the board, we rely on the expertise of our consultants in all of the work that we do. It's a significant part of our work. Dr. Bud, yeah. You can call him Bud, Buck, or... Does anyone have any questions at this point? I don't mean to just talk. Yes.
So with that kind of caseload of complaints, how do you keep your mindset towards the positive and away from geez, complaint? How do you manage that?
That is a great question. I will tell you from my personal experience, I had the privilege of working at the board first, processing license applications. So I came in at the ground level, processing license applications and interacting with those healthcare professionals who were excited and enthusiastic about getting that license and getting ready to get out there and serve the public. And whenever I'm feeling a little bit tainted by the process, and it can be, we always say you can't make up the stuff that happens in real life when you're reviewing complaints and going through investigative processes. But I will tell you that I revisit those couple of years in the licensure unit always, because the percentage of licensees subject to a complaint or investigative process, even though it's the bulk of our work, it is the vast majority of licensed healthcare professionals that never come onto our radar again after that license is issued. They are out there providing service, delivering great quality healthcare to the citizens of the state of Minnesota, and it's a very small percentage that actually comes back to us in a complaint process. So even though the number 800 might sound like a lot, if you consider it, relative to the 30+ thousand licensees and to the number of disciplinary actions that we actually take in a year, which is only about 70, we do another maybe 12 to 15 corrective actions. The vast majority of complaints do not result in discipline, which may surprise some, but I can tell you that complaints come in for all kinds of different reasons, and in many cases the complaint process, the investigative process, is remedial, rehabilitative. People make corrections without the need for the board to intervene and impose formal action against a licensee. And I think that is to the benefit of all of the citizens of the state of Minnesota, because having a whole lot of licensees with disciplinary action on their record is not really contributing productively, I don't think, to the quality of healthcare in the state. Yes, sir.
You mentioned genetic counselors, 125, whatever that number was.
Yes.
What kind of background do they have? Are these physicians typically, or what?
They are not physicians, but they are working with physicians. They do have a very specific education and training background, and they are really, the important key word here, I think, is counselors. So they are working collaboratively with an interprofessional team, typically in a hospital setting. This is not what you see advertised on television during a TV commercial to get your genetic history. That is not what the practice of genetic counseling is, just to make that clarification. But these are the people who are guiding and helping the physicians treating patients understand what some of their risks for certain conditions, whether it's a cancer, whether it's an obstetrical risk that a patient might have. So these are those people who are really looking at our genetic background to determine whether we have particular risk factors for certain illnesses and conditions, and helping their treatment providers treat them appropriately with some of those risk factors better identified. So it's a growing and interesting profession, and I will tell you that our board of physicians and public members was incredibly enthusiastic and supportive of bringing the genetic counselors under regulatory authority, because many of our practitioners were already working with genetic counselors in their practice settings, and so they felt that regulation was important and that this is a profession that really needed to be recognized and is growing, and regulation can be very important in that process. Other questions at the moment? Yes.
One of the issues that I've always had with regulatory boards, and this is not limited to the medical board by any means, is the lack of information against which to judge complaints. There's an old squeaky wheel argument about complaints, and often it looks like people have to get really bad before they really come to the attention of a regulatory board, unless they are treating, well, in the case of physicians, they're treating people who are loud enough to know how to communicate with government, let alone get results from it. And I guess there's a great opportunity for big data here, for gathering information not to judge an individual, but to exhibit what's happening out there. Preferably anonymous data, frankly, because there are things like, we can get infection rates by hospital. We can't get infection rates by individual surgeon. And that information does two things. One is it gives the power to individuals to know what the heck is right, but it also gives physicians a chance to know where they stand with respect to other physicians and decide whether, give them some motivation, in many cases, to improve their practice without waiting for a complaint. What do you think?
Well, I share your sentiments entirely, and I can tell you that as an organization, we simply don't have the capacity to have that kind of aggregate data in our possession. That does not mean that we aren't feeding information in, and I think, as you know, to your point, I think there's a lot more information sharing going on in the aggregate, certainly, and it's trying to find that one-stop shop where you can really get a lot of information as opposed to a select bit of information. And I think, is that some of what you're suggesting? It'd be great to have more information all in one place. I think with such things as the prescription monitoring program, the opioid dashboard, the FDA, yeah, so there are chunks of data in different places. And another stakeholder group that we're part of is working with the Department of Health, Department of Human Services, Minnesota insurance companies, trying to find ways that we can better share our information to do exactly what you're suggesting, to give people out there a better idea of who and to give the practitioners a better idea of where they fit in the group as well. I can say we haven't achieved the full goal yet, but that is certainly something that we are continuously working on. I do think that there's been great improvement in transparency about information over time. We do statistical reporting every year, and a few years back, the health licensing boards consolidated a lot of their statistical reports into one packaged, larger report to help people get a better sense of healthcare statistical information by healthcare providers. It certainly is a starting point. It isn't the ending point, and we continue to explore ways to aggregate our information with the Department of Health, with the DEA. Of course, we all have independent statutory authority and data sharing limitations, and that's important as well. So I don't want to ignore the fact that there are data practices requirements in place to protect everyone, to protect the providers, but more importantly, to protect the public, to protect patients and their personal information. So it's always a balancing act, but we are always exploring ways that we can improve our communication and reporting of our data. Dr. Smith. Yes, please.
Pertinent to your question, most of the things that deal with specific issues like infection rates, we'll pick on that one, are handled through the medical staff of a hospital. They're not handled by the board unless there's a specific complaint to the board. And so that does make it in one context a little more murky. And one of the issues that's troubling to me as an old guy now is that we've seen that get split out. We now have separate, it used to be all the surgeons operated in the hospital. For these and other regulatory problems, we now have separate orthopedic hospitals, separate ophthalmologic hospitals, separate endoscopy hospitals, and I shouldn't even call them hospitals because they don't use that word. That's a legal term and they would have to be regulated, but they're just surgical suites or surgical sites that are technically off campus. It makes that type of tracking more difficult.
True. Yeah,
I could add one more thing. You brought up individuals who prescribe opioids. Okay, as a cardiologist, we didn't use much of that because we didn't have need. We don't have chronic pain problems. Rheumatologists do. And so if you dump all the physicians together, the rheumatologists would stand out as individuals prescribing a lot of opioids. They would be bad physicians. Well, they're probably not. So that's the problem with some of the data that you have. You can't separate out as cleanly as you'd like.
That's a challenge. I agree. But I'd like to see somebody actively accept that challenge. We wait for epidemiological studies from academics, and that's where we get a lot of that information. But it is not generalized enough to be really useful.
Yeah, for those who didn't hear all of that, I think one of the points being made is that every specialty practices and prescribes differently. And so there is not a one-size-fits-all, because Dr. A prescribes a lot of opioids and Dr. B prescribes none does not necessarily indicate any substandard practice whatsoever. So it's a challenge to, we're looking at a lot of different specialties at this point. Medicine is highly specialized. I think the good news is that most practitioners in the state of Minnesota are now specialty board certified. So they are really going through some rigorous training in their field of expertise to gain that certification. And there is some tracking that goes on within those specialty organizations as well. But I think, I'm proud to live in the state of Minnesota and know that the bar for medical practice in the state of Minnesota is up here, even though as regulators, we are actually enforcing the low bar. We're the entry level of licensure requirements, and we are the minimum standard for enforcement. But we live in a state that really holds that bar very, very high. We're getting ready to wrap up, so yes.
I was just a question, and maybe this goes along with Dave. How is social media fitting into all of this with Facebooks and Yelps and everything else, where this is where people comment either positive or negative? And how is this fitting into your analysis or taking all this information? Because this is really being spread all over.
That's a great question. Social media, for us as a board, is not something that we rely upon in our investigative process. There may be comments, there may be information on a social media site. The board has chosen up to this point not to have a social media presence of its own. And we also have very strict limitations on how we may use information that comes from social media. So we are aware, but it is not what we rely upon to really establish our fact findings if we're in a place where we're going to take action. I did want to mention just a couple of other interfaces that we have as boards. We are, in the state of Minnesota, one of 22 states that are now members of an interstate medical licensure compact. It's very exciting. It is really enhanced license portability across state lines and created a process for expedited licensure among the member states, and that's something that we were able to get in on the ground floor. That's just been underway for a couple of short years, and we issued the first licenses just about a year ago. So it's been an exciting process to be a participant in an interstate compact, and I think other professions will be engaging in legislation to try and implement compacts of a similar. There's a nurse compact that's a little bit of a different model, and we are not a member of that compact yet, but the nurse compact is very likely to come to our legislature this session. I welcome you to contact me at the Board of Medical Practice if you have questions after you leave here today. I appreciate your interest, your questions, your thoughtfulness, and your engagement in what you do here at the Rotary Club. And if we as a board can do anything to engage with you, I welcome that invitation. Thank you very much. Sure. I brought my purple folder in the hopes that the Vikings would have.
Yeah. This year, one of our goals of Rotary International is to plant 1 tree for every Rotarian across the world. So we'll be honoring you, Ruth, as here in Bloomington by planting one of the tree for each member to honor you being here with us today. So thank you for that.